Hello, I'm Dr. Nupur Kapoor Nerurkar from Bombay Hospital in Mumbai, India, and I shall be talking about anterior glottic web management, taking the U to a we. I'm delighted to be invited for this talk, and I am from the beautiful land of the Taj Mahal, and I live and work in South Mumbai, which is a very beautiful part of Mumbai. So my focus is going to be on the anterior glottic web, though we know that glottic webs could also be posterior or sometimes even complete. So this would be a classification based on location. However, one can also have a classification based on the etiology of the web, and they could be congenital. That would be the primary focus of my talk, the anterior congenital webs. However, we know that webs can develop due to trauma, which may be external, intubation trauma, surgical trauma. It may be due to systemic disorders like vaginous, though usually in that case we have a subglottic stenosis and sarcoidosis, and of course also due to malignancy. The Cohen's classification, which is a very elegant classification, is basically the type 1, which involves less than 35% of the glottis. Usually, this is a thin, uniform in thickness web with no subglottic extension, and this usually does not warrant any kind of a surgical intervention. In fact, doing that may make the situation worse. A type 2 web involves 35 to 50% of the glottis. It could be thin or thick, and the vocal folds are usually sort of seen within the web. With a type 3 Cohen's classification, there is a 50 to 75% involvement of the glottis, and this is usually thick anteriorly going into the subglottis, usually thinning out posteriorly. Almost always the subglottic component is present. And with a type 4, there is involvement of 75 to 90% of the glottis, uniformly thick. The true vocal folds are typically not identifiable at all, and almost always this requires an emergency tracheostomy. In congenital cases, of course, that would be at birth. When we examine the web, we have to remember that there are two specific planes that we need to look at. One would be the anterior posterior and one would be the superior inferior. So we should always remember that the depth of the web also is important to estimate. And so what we are looking for is laryngeal framework stenosis. And the problem is actually compounded by the non-ossification of the cartilages at a young age. So CT scan cannot always give a definitive quantification of the laryngeal framework stenosis in children. Here is an example of a Cohen's type 1 with the anterior blunting seen. Often, as I mentioned, asymptomatic, slightly high-pitched voice may be present, and usually intervention is not recommended. With a Cohen's type 2 web, the patient usually has a high-pitched dysphonia. There may be a dyspnea on exertion occasionally, and we see here the anterior-posterior element is about 35 to 50%. And you see on the left-hand side of the screen that usually the vocal folds can be identified through the web, especially if it is thin. With a Cohen's type 3 web, the web is getting thicker. It's getting more extensive anteriorly, going into the subglottis, as you can see on the CT scan over here. And here the patients have a high-pitched dysphonia with the dysphonia on exertion, with dyspnea on exertion, and a subglottic component. Usually the anterior posterior component is 50 to 75%. Sometimes there may be a malformed cricoid, which may or may not be picked up on the CT scan, depending on the ossification. So then we go to the last, Cohen's type 4, where of course there would be a tracheostomy done because the patient would present in stridor and there is a very hoarse, high-pitched voice, always thick web, always subglottic component present. Let's talk about the management, and I am going to focus on the Cohen's type 2, especially that which is congenital in nature. So how can one manage a Cohen's type 2? There are various surgeries described. Whenever there are various surgeries, it's because no one surgery is perfect in every situation. One can perform a cut in the midline, especially for the thin webs. You may or may not want to apply mitomycin. I used to, I have more or less stopped now, but it's important to clean the slough, and we'll discuss that later. Creation of microtrapped or flap to cover one vocal fold, salastic Keel placement after cutting of the web, which may be The exposure may be achieved endoscopically or through a laryngofissure, and a double flap surgery. I've highlighted that in red because that is currently my go-to surgery for the Cohen's type 2 web. As far as the Cohen's type 3 web is concerned, keel placement again is an option, which could be endoscopic or laryngofissure, a butterfly surgery with cold steel, and what we've described as a double flap endoscopic coring technique, which I shall also discuss. And in a Cohen's type 4, open surgery, which is a laryngotracheal reconstruction with augmentation of the rib graft, which I shall not be discussing in today's talk. So here's an example of a Cohen's type 1 web where the web is very thin. So we are cutting in the midline with the AccuBlade. That is the red line you see over here, bang in the center so that we create the two vocal folds. This will, in most certainty, re-web if you don't do something about it again. So firstly, we don't give these patients voice rest because we want the vocal folds to keep abducting. In fact, we give deep sniffing exercises, and we also like to give steam. We also like to give sterile water nebulization or saline nebulization to these patients. What is very important is to clean up this dead skin or slough which develops 7 to 10 days later, which almost always will develop, and if left untouched will form the restenosis. And this slough or dead tissue is so thick that it's not easy to sort of just pluck it out under local anesthesia. So we typically take the patient under short general anesthesia for 5 minutes and actually peel out the entire slough or the dead tissue, because that is what results in a good healing for the patient, basically. And this again, we follow up with the sterile water or saline nebulization, and we continue with the deep abduction exercises. Sometimes it's necessary to perform this cleaning of the slough twice. So on the 7th or 10th day, and again, maybe after 3 weeks. So we keep a close follow-up on the patient and see how the healing is. Usually in 4 to 6 weeks, the complete healing does take place. Here is the preoperative voice of a patient who was operated by just a midline cut with a laser.
I'm from Hubli, from Karnataka, and I'm studying in engineering final year. And since I have this problem from my childhood, I feel that my voice is quite feminine in nature. And I feel much difficult in the crowd to speak, and I feel my...
And let's hear his voice 2 years later.
I'm from Hubli, Karnataka. I have gone through a web operation 2 years ago, and now new people won't even recognize the problem which I had earlier. And these days I feel very good. 1, 2, 3, 4, 5, 6, 7, 8, 9.
Moving on, we have the endoscopic mucosal microtrapdoor flap creation with suturing surgery, which has been described. And here is an example of this surgery. So basically what is being done, again, you see the red line there, which is the AccuBlade of the CO2 laser, which is being used in a scanning mode. So an incision is being made on the imagined right vocal fold medial edge. And that results in the creation of a triangular flap, which is actually the flap of the web itself. The undersurface of this flap is then freshened, and the flap is then sutured to the left vocal fold from superior to inferior. So these are vicryl sutures being taken with the 6-0 vicryl to suture the epithelium onto the undersurface or the infraglottic surface of the left vocal fold. The idea is at the end of the surgery, one has one vocal fold which has got an epithelial cover. The knot is taken outside and it is slid down with a knot slider. One can also take this knot inside the larynx, which I personally find technically more challenging. This is another suture being taken so that we get a better cover of the epithelium, even anteriorly. So with one epithelium present, one side, and the other side raw, the healing is better.
Just take that.
See the suture on the left vocal fold, and we can see the good healing at the level of the anterior commissure. Another option of surgery is basically the endoscopic keel placement, where we are cutting in the midline once again, like the first surgery I showed you. This is usually done for thicker webs, but because the web is thicker, we place a keel made of a silastic sheet, which is like a butterfly keel, endoscopically, and then remove it after 3 to 4 weeks. So an example of this surgery is being demonstrated now. This, as you can see, is a very thick web, so laser-safe tube in situ, and we are doing the cut again midline. This is not a cut on one side, because the idea is that though there is going to be no epithelial cover and there's going to be a bilateral raw area which is thick, we are going to have a keel in place for 3 to 4 weeks while the epithelialization is taking place, and then one goes in again under GA, short GA, and removes the keel once the epithelium has sort of healed over. The keel placement sometimes can be tricky, and it can be easier to perform if you have a Lichtenberger needle, but it can also be performed without it, just by using Venflons and guiding the suture through them. And so here the web has been opened. We put the Venflon in at, one Venflon is placed below the level of the vocal folds and one above the level of the vocal folds, so that the keel can cover that entire length, or I should say the depth of thickness of the web. And a 1-0 Prolene suture is passed through the Venflon, which is then pulled out endoscopically, and then it is threaded into the keel, the silastic keel which you have, which is like a butterfly keel with a little, you may want to just stitch it in front, or you may have an infant feeding tube in the front suture through which it can be sort of fed into. And the other end then of the thread is passed through the subglottic, and the keel is placed in the midline as over here. And finally, let me talk about the double flap surgery for the glottic webs, which is my current preferred surgery. Over here, what we're doing, this is palpation, infiltration to bulk up the thickness of the anterior glottic web. And now we are creating once again an incision on the imagined right medial edge of the vocal fold. Small bit of tissue here is being excised in this particular case for histopathology, because we did not know the etiology in this patient of the web formation, because it was no history of trauma. So we presume congenital, but we weren't sure because the hoarseness happened as per the history at about 16 years of age. Now you see with the cold steel with scissors, we are cutting the web, but only in half thickness. So it's not the entire web being cut. We're cutting it in half thickness up to the imagined left medial edge of the vocal fold. So then at the end of surgery, you have two webs now. You have one web on the right side attached to the infraglottic surface of the right vocal fold, which is being sutured to the supraglottic epithelium of the right vocal fold. And we also have the superior part of the web attached to the left vocal fold, which is now being sutured to the infraglottic epithelium of the left vocal fold. So therefore, this surgery is even better than the single flap surgery, because we are covering both the vocal folds with epithelial flaps, and therefore the chances of syncytial formation again become obviously less. These surgeries are technically a little challenging because you are suturing and sometimes the flaps tear. One can, in that situation, try to use fibrin glue. However, the suture is a much better technique to use. Let's hear the patient's voice preoperative.
1 2 3 4 5 6 7 8 9 10.
And this is the voice.
1 2 3 4 5 6 7 8 9 10.
And I would like to now talk about the management of congenital anterior glottic webs, which have a laryngeal framework stenosis, and how we use a double flap endoscopic coring technique. So the double flap surgery remains the same, but because of the laryngeal framework stenosis, there is an endoscopic coring also involved. So to just describe the method, basically, this is for patients with a type 3 congenital Cohen's web with laryngeal framework stenosis. And the surgical steps basically include a CO2 laser accublate incision along the imagined medial edge of the right vocal fold, continued down to the stenos, thyroid, and cricoid cartilage on the right side. The tissue of the web is basically elevated. The anterior stenos laryngeal cartilages are then elevated with the microflap elevator, as you can see in the diagrammatic representation. And you often have an unossified but stenosed cartilage, which then can be cored out using both sharp upward scissors and sometimes even the CO2 accublade. And the laser excision is typically easy and chaff-free because it's a soft nature of this unossified congenitally stenosed cartilage, usually is what we've seen. Care has to always be taken to preserve the subglottic mucosa, which is then carefully delineated while removing the anterior stenosed cartilage. And then incision is then made in the subglottic mucosa near the left border of the cartilage. So here we are using not two flaps in terms of thickness, but one is going to be, the left flap is going to actually be the mucosa, or which is found in the subglottis. And the subglottic mucosal flap is then sort of stuck upwards with fibrin glue because we find it more technically challenging here to cover it. It's more challenging to use suture. It's easier to use the glue in this situation. And the glottic web is turned in a downward direction from the right side and again stuck onto the subglottic mucosa. So here is an example of such a patient where an incision is made on the right side. You see that white area over there, which is the ossified cartilage of the thyroid and cricoid. And as we core it out, you see the black delineation. When we are coring it out, more and more of the tissue is being cored out, as you can see over here. And we start seeing the subglottic mucosa, more of the subglottic mucosa being visualized. And then we cut the flap of the subglottis. And so we have one flap downwards and one flap which is moved upwards. And this is the patient's voice. 1 to 5 bolo.
1, 2, 3, 4, 5.
She hardly has a voice. 2 weeks later.
1, 2, 3, 4, 5.
A louder voice, still the hoarseness is present.
1, 2, 3, 4, 5, 6.
This is a much better voice at 6 months when complete healing has taken place. This is another example of the same surgery being performed in a slightly older patient. Again, using the infraglottic mucosa on one side, on the right-hand side, on the left-hand side, the glottic web epithelium, and the preoperative voice.
1, 2, 3, 4, 5.
And 3-week post-op voice.
1, 2, 3, 4, 5.
So we did remove the post-operatively. The slough was removed under general anesthesia in about 2 weeks' time in the adult patient, and then again in 3 weeks' time. But it's important to note that neither of these patients, which I showed you, required any kind of stenting or tracheostomy, though consent was taken for both preoperatively. And just want to end with an interesting slide of, we've been talking about how to take care of a web when it's present, but sometimes in a normal vocal fold, you actually create a Cohen's type 2 web. And this is in a situation where you are doing a feminizing laryngoplasty. So here the accublate laser is being used to laserize and de-epithelize the anterior 50% of the membranous vocal fold. And sutures are actually being taken here with 6-0 Vicryl to suture together the 50% of the membranous vocal fold anteriorly to create a nice uniform web with a sharp V. So what one is doing is shortening the vocal folds and creating a masculine vocal fold into a feminine vocal fold, because when we decrease the length of the vocal fold, the pitch automatically goes up. So this is a surgery which we have been performing very much more frequently of late for the trans women patients. And we have the International Association of Trans Voice Surgeons, which was formed in 2022 in Berlin, of which I'm a founding member, which has now been, it's growing by leaps and bounds. And this is something where you're doing the opposite of taking care of a web. So it's a bit difficult in the beginning. You wonder what you're doing, but the results are very gratifying. This is the voice pre and post-op.
Start.
This is the masculine voice. And this is when the web has
1, 2, 3, 4, 5,
three.
6, 7, 8, 9.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And one of our trans women, this is what she has to say.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
4 हफ्ते पहले की है वेंट्रस ग्लॉटोप्लास्टी। आपको कैसे लग रहा है आवाज?
सर्जरी करने के पहले मैं तो बिल्कुल भी हैप्पी नहीं थी मेरे वॉइस से, फर्स्ट ऑफ ऑल तो यही। और सर्जरी करने के बाद में मुझे खुद इतनी एक्सपेक्टेशन नहीं थी कि इतना जल्दी रिकवरी हो जाएगा।
Basically, she's saying that she's extremely happy with her voice and she didn't expect her voice to become so feminine and so quickly. So it's really a gratifying surgery. Both of them, whether you're taking care of a web which is present to improve the voice of the patient, or you're creating a web for a trans woman. What is very important to remember is that if you have a sharp anterior V, and a good closure with no phonatory gap, then the voice will be good. But if you have an anterior U with an anterior phonatory gap, then the voice is going to be with hoarseness and air leak. So with that, I'd like to thank you. Also, I have 2 QR codes. The one on the right-hand side is my YouTube channel, and the one on the left is the QR code for the phonosurgery workshops, which we have every year. And you are, of course, always very welcome to attend. Thank you so very much. It's indeed been a pleasure to talk with you all.